Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
Hello, so I see you made the appointment today because you've noticed some bruises on your legs?
Yes. At first I thought I might have bumped into something without noticing. I did not think much of them at first. You see, people get bruises all the time, but then these purple badges of honour, as I called them initially, didn't go away as they should. That was when I started to pay more attention to them. And when I see more of them, I felt I had to see someone.
So how long ago did you start noticing the bruises?
Was it 2 months ago? No, I don't think it was that far back. If I had to put a finger on it, I'd say probably about a month and a half ago. Yes, that should be right about the time I had that first bad menstrual cycle.
Bad menstrual cycle? What do you mean by that? Was there a lot of cramping?
No, no pain or anything of the sort. It was just abnormally heavy. I am 36 years old, and so I'm pretty familiar with my cycle, but these last two periods made me feel like a teenager all over again.
I see, and any other unusual bleeding?
It's funny you should mention that. Yes, I had a major nosebleed about 3 weeks ago. It was so strange because I've never had one in my life before then. But one day I was at work and in the middle of a phone call with a client, and boom, I noticed blood dripping on my desk. It took about 15 minutes or so to stop.
I see. That must have been quite distressing for you to have that happen at work. Does anyone in your family have any bleeding disorders?
No, not that I'm aware of.
Right. And have you made any changes to your lifestyle recently, such as starting to drink or smoke?
No, not at all. I've never smoked and I only drink occasionally, like at parties or social events, things like that. I have an 11-year-old daughter to take care of, so not much time for going out and drinking.
So I can see that you have multiple areas of purpura on your legs. Here are some more on your abdomen and arms, but these are not as severe as the ones on your legs. They vary in colour quite a bit, from black, purple to yellow.
Yes, that is how they've been for the last month or so. More on my legs and with a rainbow of colours.
I also see that you have two bullae in your mouth. Have you had any incidents of your gums bleeding?
Yes, a bit, like when I brush my teeth, but it does seem to take quite a long time to stop. Oh dear, are all these bleeding episodes related to my bruises?
Well, we'll see if we can figure that out today. So here I have the results from the blood tests that I ordered when you called in to make the appointment. There are a few areas of concern, such as your hemoglobin is slightly lower than the normal range, but that is not what is most concerning. What worries me the most is that your platelet count is far below the normal range.
How far below? What does that mean?
Let's just say that your platelet count is almost non-existent compared to what is normal. To put some numbers on it, people normally have 150,000 to 450,000 platelets per microliter of blood, and your platelet count is at 4,000.
Oh no, you are right, almost non-existent. But what does that mean?
Platelet defects can cause spontaneous purpura or bruising on the skin, and they can also result in unusually heavy menstrual flows and bleeding from the gums or nose, all symptoms that you have experienced. Other symptoms include prolonged bleeding from cuts, bleeding in urine or stool, and jaundice, which you are not experiencing at this time.
So what causes it?
There are two possible causes: reduced production of platelets or decreased survival of platelets. We'll have to run further tests to see what category you fall into, but for now you are going to be immediately referred to the hematology unit for a platelet transfusion. With platelet counts so low, you are at a high risk for a major spontaneous bleed.
And is this something I will have to deal with for the rest of my life?
Yes, unfortunately. The disease tends to run a remitting and relapsing course, but as long as it is managed.
Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase.
How are you today?
I'm okay, Dr. Silverson, but do call me Sally.
Yes, Sally. So we saw each other a couple of months ago for your yearly checkup, so I was quite surprised to see your name down for an appointment today.
Yes. Dr. Silverson, I hesitated to make this appointment because there really isn't anything specifically wrong with me, but I just cannot shake the feeling that something is wrong.
What do you mean? I mean, if you feel poorly, then something is likely wrong, especially considering that you did turn 85 last month. Can I just say, you don't look a day over 65, but records don't lie.
Thanks very much. I have actually been telling people I'm 70 to see if I can get away with it. Wow. Yes, you are right. My age makes any health issue more serious.
So what seems to be the problem?
Well, I've been feeling so tired lately. I started noticing it when I had my grandkids over for Christmas. That was 4 months ago, was it?
No, Christmas was a good 6 months ago.
Oh, dear me. Where has the time gone? So, yeah, if I were to trace it to a time when it started, I'd say Christmas. But when I came to my checkup, I didn't mention it because I just thought it was, well, old age, I guess. But I'm still feeling quite tired, months later.
Okay, anything else besides the tiredness? Any loss of appetite or nausea?
Now that you mention it, I've not had much of an appetite lately, and I do sometimes feel a bit nauseated.
Let's see how your weight is looking. Oh my, so when you came in for your checkup a few months ago, you'd lost 1 kilo, which wasn't so alarming at the time, but since then, you've lost 7 more kilos in just a few months.
Seriously? I knew my clothes were a bit looser, but that's a lot. Also, I just in the past 3 weeks started experiencing some generalized itching and cramping in my muscles. It comes and goes, but I think it started about 3 weeks ago.
So let's see. I can see that along with these recent changes in your health, you have also been hypertensive for the past 2 decades.
Yes, and I've been taking my antihypertensive medication for that long as well.
Wait a second, your blood pressure is very high, 190 over 110. We will need to change medications to get it under control.
Oh my, that is very high. I promised Doctor I take my medication every day at the same time, right after that Meals on Wheels service delivers my lunch. I never forget. And my daughters are very good about filling my prescription.
Other than that, do you have any other problems of late?
Well, my girls sometimes comment on my eyes. They say the red reminds them of the time one of them had conjunctivitis. I'm sure they're just exaggerating, but yeah, I guess that's just how it looks. It's not bothering me though.
Right. Anything else?
Gosh, if I want to really tell you everything, it'll be a shopping list. But if you must know, this old woman sometimes gets split-second dizzy spells. I could be standing washing the dishes and I would get this feeling that just passes. I'm sure it's nothing.
Well, it may be associated with your hypertension. Let's just be sure. Here's what is going to happen next. I'm going to send off for some blood tests to check levels of urea and creatine. But the symptoms that you're describing, lack of appetite, nausea, weight loss, fatigue, cramping and itching, they're all consistent with end-stage renal failure. Also, it is essential that I do a renal ultrasound. It will allow us to accurately size the kidneys as well as identify causes for renal failure.
Renal failure? But I thought the problem was with my blood pressure.
Yes, it is, but hypertension is damaging to kidneys.
Will I need dialysis? I have had some friends who have needed it and it seems awful.
You may need it, but there are many possible options, such as a hospital and home-based dialysis. We will cross that bridge when we get to it. For now, I am more concerned about...
That is the end of Part A. Now look at Part B.
Part B. In this part of the test, you will hear 6 different extracts. In each extract, you will hear people talking in a different healthcare environment. For questions 25 to 30, choose the answer A, B or C, which fits best according to what you hear. You will have time to read each question before you listen to the audio. Complete the answers as you listen to the audio.
Now look at question 25. You hear part of a ward briefing. Now read the question.
Hello and good morning everyone. I want to start off today's briefing with a reminder about confidentiality. Confidentiality may seem a very straightforward principle, but translating principle into practice can be problematic, particularly in emergency situations. We often find ourselves in all sorts of situations where it may be difficult to know if patient information should be shared or not, such as with social workers, and that is the particular issue that I want to address today. We must keep in mind that social workers have no more right of access to confidential information than anybody else, except in a limited number of situations, such as when the patient has given consent to the release of information, court order, or when the public interest in disclosing information outweighs the public interest in preserving patient confidentiality. For this last condition, we must look to what the law says. The Data Protection Act lists a number of exceptions that would allow for patient records to be
Question 26. You hear 2 nurses having a conversation. Now read the question.
Do you ever feel that a lot of what we do is just talk to people?
I suppose so, though I wouldn't put it that way, just talk to people. The way we communicate with patients is an important part of our jobs, especially since doctors often don't have the time to do so.
I'd never really thought of it that way. I mean, I guess I think about my job as providing healthcare to people, but as a nurse, making patients feel comfortable with care is also important.
Exactly. I mean, think about the times when communication with the patient has gone poorly. It has a negative effect in many ways: patient compliance, stress levels of both the patient and us, the nurses.
It reminds me of when I used to make home visits. So many of my patients just wanted to have a moment to talk with someone about their day and also their health concerns. I mean,
Question 27. You hear part of a conversation between a GP and a nurse.
So, Dr. Charles, I had an idea I wanted to run by you.
yes, Mrs. Nelson, what is on your mind?
Well, as our patient load has been increasing, I've been thinking of ways to make appointments more effective for all of us, but most importantly, patients.
Definitely. I have been thinking about the same thing myself, but I just haven't had a lot of time to do much investigating.
Well, I came across a list of tips for patients to use to make the most of their consultation time. I was thinking we could include this list, perhaps along with a short video, in an email that we could send out to patients with their appointment confirmation.
Interesting idea. I mean, it definitely can't hurt, and it probably won't take a lot of time on our end. Can you tell me about some of the tips?
Certainly. Well, the first is quite simple: write down a list of questions and concerns before your appointment. And the next is be prepared to take notes about what the doctor says. The next is
Question 28. You hear part of a training on an addiction treatment program. Now read the question.
welcome, ladies and gentlemen. Thank you very much for taking the time to learn about the NIH's trans-agency effort, the Helping to End Addiction Long-Term Initiative, or HEAL initiative, to stem the national opioid public health crisis. Nearly every institute and centre that forms part of the NIH is working to accelerate research to address this public health emergency. The initiative is finding and bringing together hundreds of projects nationwide to help researchers to take a variety of approaches to tackle the opioid epidemic. The HEAL initiative's research priorities seek to address unmet needs, areas of scientific opportunity, and strategies to create solutions to the opioid crisis. One example of a funded program is focused on optimizing collaborative care for people with opioid use disorder and mental health conditions. I'm going to talk about this program in detail for the next few minutes in order to give you a better idea of the type of research we are looking to add to this effort.
Question 29. You hear part of a conversation between a junior and senior doctor. Now read the question.
So, Dr. Stewart, I'm going to explain a bit about how we do handovers here at the hospital.
Thanks, Dr. Jones. I've heard that the hospital has a very good system here, particularly the paediatric unit, so I've been wanting to learn about how it works.
Yes, so every morning we have a multidisciplinary handover at 9 a.m. It's led by the senior nurse on duty and the consultant of the week. This handover takes place in a specific room, and all of the outgoing night team and the incoming day team attend.
Okay, so that's the morning handover. What time does the afternoon handover take place?
That happens at 4:45, and then there is an evening handover at 9:30.
Okay, so there are 3 handovers a day. And what?
Question 30. You hear part of a conversation between a junior and senior doctor. Now read the question.
Dr. Alex, would it be okay if I explain what I'm seeing in this chest x-ray to see if I'm on the right track?
Absolutely. So what do we have here?
So, I'm seeing what I think is a lung mass here. Do you see it? It is in the anterior part of the first rib, near where the bone meets the calcified cartilaginous part.
Oh yes, I see it. Well, some patients have an extra joint there that can simulate a lung mass.
So it isn't a lung mass?
Likely not, but you might consider getting another angle to see.
That is the end of Part B. Now look at Part C.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about specific aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete the answers as you listen to the audio. Now look at Extract 1. Extract 1. Questions 31 to 36.
You hear an interview about the use of technology in medicine. You now have 90 seconds to read questions 31 to 36.
Hello everyone and welcome to the first in our special series of lectures on medical breakthroughs. Today's guest is going to talk to us about a recent discovery in the use of machine learning. Welcome, Dr. Atkins.
Thank you very much for your kind introduction. I'm very excited to be here today to talk about my team's research.
So, let's start off by having you give a brief introduction. I mean, this is an area that is completely new, so we need to have a foundation before going into the details.
Of course. So, my team has recently discovered a neural signature that can help to predict whether individuals with depression are likely to benefit from sertraline, a commonly prescribed antidepressant medication.
That is wonderful news. I know currently doctors often use trial and error to find the best antidepressant for a patient. This discovery can help patients on the road to recovery a lot faster.
Yes, there is a great need in psychiatry today for objective tests that can inform treatment and go beyond some of the limitations of our diagnostic system. And this research helps to get us closer to that goal. As a researcher, I am particularly excited about these findings because they show the potential of bringing sophisticated data analytic methods to psychiatry.
So let's go more into the details of those sophisticated data analytic methods.
Okay, but first, let me back up a bit to some previous research that led us to this current research. So, earlier research suggested that specific components of brain activity, as measured by resting state electroencephalography, could give us some insight into how people will respond to certain treatments. So we used this insight along with insights from other fields such as neuroscience, clinical science, and bioengineering to build an advanced predictive model. From there, we developed a new machine learning algorithm to analyze the electroencephalography data.
Okay, and what exactly is the model predicting or analysing?
The idea is that the algorithm can identify robust and reliable signatures of antidepressant treatment response. We use the algorithm to analyze data from participants in a large clinical trial of the antidepressant medication sertraline. Specifically, we apply the algorithm to the participants' pre-treatment data to see if machine learning could produce a model that predicted participants' depressive symptoms after treatment.
Okay, just to make sure I understand. So you knew there was a way of analysing brain activity to see how well patients would respond to a particular medication for depression?
Well, I wouldn't say we knew, but that was our hypothesis.
Yes, of course. So what were the results of the study?
Well, the machine learning algorithm was able to reliably predict individual patient response to the medication based on a specific type of brain signal, alpha waves. In fact, this model based on electroencephalography data outperformed conventional models based on other types of data, such as symptom severity or demographic characteristics.
That sounds like great news. I do have one question. So you said this algorithm was able to predict participants' response to this particular medication. Let's say it predicted that this medication wouldn't work for a participant. What does that mean?
Great question. So, participants that the model predicted little improvement with this particular medication were found to be more likely to respond to treatment involving a specific type of non-invasive brain stimulation called transcranial magnetic stimulation.
I see. And is there further research in the works using this machine learning algorithm?
Certainly, analysis suggests that the predictions made by the algorithm may extend to broader clinical outcomes beyond the response to this particular medication. And of course, we need to replicate these findings in larger samples to determine the value of the algorithm as a diagnostic tool.
Exciting. We will certainly be hearing more from you and your team. So now I want you to look big picture for a moment. What do you think will be the future impact of machine learning on your field?
Wow, that is a big question. But if I had to make a prediction, I mean to say what I'm most excited about, it would have to be the potential of machine learning for advancing a personalized approach to treatment, particularly in depression.
That is certainly something to be excited.
Now look at Extract 2. Questions 37 to 42.
You hear a presentation about a way to reduce the risk of tooth decay. You now have 90 seconds to read questions 37 to 42.
Hello everyone. Today I'm here to talk about a very simple and low-cost way of reducing the risk of further tooth decay in young children by more than a quarter. Yes, by more than a quarter. So first, let me back up a bit and tell you about the statistics that prompted this research, as well as the research that helped us come to this finding. First of all, nearly a quarter of all 5-year-olds in the United Kingdom experience tooth decay. In particular, children from the most deprived areas have more than twice the level of decay than those from the least deprived. Another statistic that some of you may not be aware of is that tooth decay is the single highest reason for children to be admitted to hospital, with nearly 34,000 children aged 9 or under admitted to hospital to have teeth extracted in the last year. In addition to causing pain, sleepless nights and days of missed school and work for children and their families, each extraction costs the NHS around £1,000 and normally needs to be done under general anaesthetic. We can certainly say that this is an unpleasant experience for all involved and a completely avoidable expense. In addition, evidence shows that children who have baby teeth taken out are much more likely to get decay again in their adult teeth. Recent research in this area suggests that parents often know what has caused the tooth decay in their young children, but find it very difficult to change habits, so they find it hard to know where to start. So, the trial that led us to the finding I mentioned at the beginning of my presentation took place in 12 centres in the United Kingdom and involved over 200 families of 5 to 7-year-old children having baby teeth extracted in hospital. In order to tackle the problem of tooth decay and difficult to change habits, my research team developed a talking intervention for trained dental nurses to have conversations with parents of children who were having teeth extracted. The conversations with dental nurses focused on how families could prevent tooth decay in the future and on how to choose goals that they felt they could achieve. To give you an idea of how this approach was different from what is normally done, here is what one of the nurses involved in the study had to say. She said that she finds that if we give lots of information and guidance all at once, it can be overwhelming for parents. In this trial, we help families choose 1 or 2 actions. For example, it might be to help brush their children's teeth at night or stop giving a sugary snack at bedtime. It became the parents' goal, not ours, and so they could see a way forward and they took ownership of the situation. 2 years later, we compared outcomes for these children with those who had been given standard advice after regular visits to the dentist. And we also asked the children's dentists about care provided. We found that nearly 2/3 of children in both groups went back to the dentist. However, the children whose families had not spoken to the specially trained dental nurses needed many more fillings. Children whose families had set their own dental health goals had significantly healthier teeth and had a 29% lower risk of having new tooth decay. Our main conclusion from this research is that when we change how we talk to parents about prevention, their children go on to develop fewer cavities. The key is helping parents to choose 1 or 2 behaviours they feel they can change for their child, rather than us telling parents what to do, and that makes the difference. So it turns out that a simple and cost-effective method to reduce tooth decay in small children is a conversation, one that seeks to create a partnership between parents and dental service providers. I think we can also all agree that this is much more pleasant for all involved, and the habits established by the children involved in this study will likely have a positive effect on all areas of their health. We are currently in the process of developing our work into a training module for dental nurses in the NHS and hope to make it available in the next couple of months.
That is the end of Part C. You now have 2 minutes to check your answers.